Okay, perfect. So maybe what I'll do is, so we have, I've kind of broken down this session into two or three major buckets. The first one is which I call a kind of an icebreaker. Typically in physical sessions, we were able to, do this much before and also with the audience. But I'll kind of go one by one and ask a few questions that will maybe hopefully allow the audience to connect with each of the panelists a little better. Eric, I'll start with you. Eric, you're in Mount Sinai, and I must say, right, one of the key things that we've been listening to is that Mount Sinai is at the center of this entire crisis. My co-managing partner, Nilesh, who manages our US business, his son is actually working as a physician, frontline physician in your hospital, and we get regular updates on the war stories and kind of heroics you guys are doing. So I think firstly, salute to all of you for sure. And we've seen, Eric, that you've been in this system for multiple years. You've been at Rochester, you've been in Hackensack University, you've played roles in giving back to the community. And again, so what has been how is it that you've been able to adapt to this sudden change on both the work and the life front?
Yeah, I could probably go into this for quite a bit of time, obviously, with the just the massive hit that we took from the pandemic. But I mean, just to give you a tiny bit of background before the pandemic came in, we are a virtual urgent care platform, right? We started off primarily with our own internal employees, like many organizations do, and then we started to expand out to a larger population. But the relative program was very new, even before COVID hit. So you're talking about maybe seeing 10, 15 patients a day, and within 3 days we were seeing 300. We had a staff of 25 providers before COVID hit. We trained 300 plus providers in 7 days. This ranged from ED, every specialty in the hospital. You can imagine the ED was just slammed, right? And obviously, that was the front line. So they were inundated with, the sheer amount of patients that they were seeing during this. So we had to go in and dip into the organization and really reach out to everyone and anyone that we could to really get as much possible help that we could. So we had ED providers, we had residents, we had mid-levels, and we had physicians from all walks of life. I mean, everywhere. Occupational medicine, ortho, neurology, even hadn't their care space. It required a all hands on deck effort. I was primarily from my house, 15, 16, 17, or 24. We used platforms to kind of help us. We made specialists, director, and other physicians that pitched in. Apps like WhatsApp just to kind of allow the providers to speak about cases. Obviously, not anything with PHI or anything like that, but just about what they are seeing and what kind of cases they were dealing with. We used Slack so that we can disseminate tip sheets and create things on the fly, things that might have changed from a compliance perspective. I mean, really, it was just kind of pulling in all of our resources and trying to figure out how to handle it best. And we had roughly 25 to 30 providers per day on our platform, and like I said, handling at a peak, 250 plus patients daily for roughly 8 weeks. So it was quite a change. But it was very, very interesting and very, proud of the organization to see how everyone pitched together and really brought things, full circle. Because we weren't ready. We really weren't, as best as we could have been. But it came along pretty fast, and we were able to adapt. And it was really quite an experience.
Perfect. Thank you so much, Eric. Rakesh, you've been associated with the clinical space for about 2 decades, and you've looked at diverse roles in visual simulation for surgeons, drug databases, and prototypes for US Army, and you have led digital innovation and virtual health even in pediatric hospitals. What has been the driving force in exploring these diverse sets of functions across different organizations?
No, I want to say I'm a glutton for punishment. No, just kidding. But so it's a chuckle, right? So the things that we work on, visual simulation and things like EMR. So I mean, like all those things, they are on the cutting edge. Innovation itself is a cutting edge. And like back in the days of bootstrapping, when venture capital was not so readily available, gosh, those were the difficult days, right? When you actually had to show revenue. So these are different and interesting times now where you don't actually have to worry about revenue. So no, it has been an exciting journey. I mean, having a clinical backdrop, and I see more and more physicians. Actually, I was a physician in India. I see more physicians now, younger physicians jump into this space and sort of be the CMIOs and the digital officers and such. So healthcare. So who better to do digital technologies in healthcare than providers, right? So that has been sort of my motto, and it's been an exciting journey. I kind of like got into the virtual health space as a co-partner of innovation. So at one of the largest, actually the largest pediatric hospital in the country, we were in that space as innovation because frankly nobody knew where to put virtual health back then. So they put it under innovation, and still it reports up to innovation in several places. But over the last 5, 7 years, it's been very exciting, right? So we now see virtual health, and I would say in the last 15, 18 months now even before COVID, I see a tremendous pivot, right? So with all the venture capital flowing into sort of value-based care, we do see a lot of exciting things coming up in this virtual space. And like as Uma mentioned, virtual is not. People typically think about that as telemedicine, which is just the audio video
Mhm.
component. But there's also the remote patient monitoring, all the M health. So depending on how your role is designed, I mean, my scope is over these three pivotal things, and it's very exciting. So if you think about all these patients of chronic disease management, right, the 80-20 of healthcare, the 80% of the costs are being driven by 20% of the population. All
Right.
that care can be delivered sort of virtually. So we think about virtual in that broader perspective, and it's been an exciting journey. So the strategically we see so many avenues even beyond the classic telemedicine. Although right now we kind of like
Right.
heads down focus on the telemedicine aspect.
Thank you, Rakesh. Stuart, coming to you. Firstly, thank you so much for wearing a full suit. It is so rare to see it nowadays, and I'm actually glad I could see someone from being a consultant who almost wore it every day to not even looking at it. I think thank you so much, Stuart. Firstly, Stuart, you've been associated with the University of Florida throughout your career, right? Unlike most of us who have hopped ships different stages of our career. Uh, and you've closely seen the university evolve from what it is to where it is now. What has been your biggest motivator to continue this long journey with UF? Stuart, you're on mute.
I apologize.
Yeah.
Thank you very much. I guess it's been just what you were saying. For me, the journey of seeing this institution grow, I arrived here in 2001, so it's been about 20 years, and I've had a couple different roles, both in healthcare and in healthcare IT, and growing it and being, for my passion is learning and education. And I don't know how many folks on the call are familiar with Publix, but I used to work there through high school and college. So customer service is very important to me as well. You can kind of see where this is going with virtual care and making patients comfortable without having to come to the doctor's office and being able to get care from the comfort of their own home. I'm very much about learning and innovation, and I'm going to echo what Rakesh and Eric were just speaking to, so I don't want to repeat it all. But um, this spin up, I've been in this telehealth role for about 4.5 years now. This spin up is unprecedented to anything I've ever experienced in my professional career. We went from doing, honestly, we're a larger, I work in the group practice primarily and as well as the hospital, but in the ambulatory world, we have roughly 1,500 care practitioners. We went from doing about 20 visits a day to close to 1,800 a day at the peak in April. We're now around 700. one of the things that I love, so you asked why UF, one of the things that I loved about this experience, aside from the energy, and I do try and look at things positively that way, because you have to stay positive or it can easily just sweep us all away with this pandemic. But one of the things that has been neat and struck me was the nimbleness of a large entity like UF Health to very rapidly adapt to a new role. I have a very small team here longitudinally. We're a team of, on the administrative leadership side, 3 people in virtual care. We actually grew to a team of 40 to get everything spun up. And that meant in literally 3 days, we had 40 people working for us. And coordinating that and the whole nimble support from leadership down was awesome. So that's kind of why I love being here at the flagship university. I love seeing it evolve. And I believe, as Rakesh mentioned, the next bit of this is going to be innovation. Where do we go from here, from it just being telemedicine to, as you were saying, like innovated, connected M-Health? How do we make this virtual care, if you will, the Netflix of the future for healthcare?
Wow,
So
that's a good one. Yeah, Netflix of the future. Okay, that's a nice one. Tyler, coming to you, you have been associated with Centara Healthcare right from its inception and almost the driving force behind its virtual care journey. What was the vision of telehealth in your mind when you started this journey, and how do you think it has maybe leapfrogged or rapidly evolved in the last 3 to 4 months?
Yeah, good afternoon. It's good to be with you. I appreciate the question. So yeah, I came into the virtual care side after spending some time on the mergers and acquisition side within the medical group. And here at Centera, it sounds like we're fairly similar to UF. We have just about 1,600 providers, 12 hospitals located in Virginia and North Carolina, and an insurance plan as well. And all of those factors contributed to why we started virtual care. And really, we started it a few years ago to improve access, and then to provide that patient expectation to get care when they want it, how they want it. So really, those were the 2 driving factors: were access and then patient demand. And we stood up our direct-to-consumer team, and we built our Centera app, and we had integrated virtual care into all of our practices and even in our hospitals, so they could directly refer patients or schedule patients onto my telehealth team schedule. So if a patient called to practice and needed a same-day visit, but they didn't have capacity that day, or the physician wasn't available, then we push them right to my team. And that worked well. And once we got that going, our plan was to then expand virtual care into all of our provider offices. So my goal starting in January was to bring up 500 providers by the end of this year, doing virtual care to their patients within their offices, and then finish the medical group in 2021. And then COVID struck in March, and we brought up everybody, over 1,600 providers in about 2 days. And we went from doing 20, 30, 3,000 a day, and it is pretty exciting. The team I have is just incredible. So we're super grateful for them. And Dr. Mark Haggerty, absolutely, it's incredible.
Perfect.
So that's where we've been. Is we've jumped ahead 2 years integrating virtual care throughout the medical group, and then now what we're working on, because it's now been integrated, is we're working on unlocking the clinical and operational efficiencies that virtual care lends itself to. So decreasing the amount of time it takes per visit, improving that patient experience, decreasing the number of staff needed to support virtual care, so we can have autonomous providers doing this. So really looking at how do we optimize the efficiencies virtual care can provide. And then the second thing that we're working on now is really looking at unlocking, or not unlocking, at bridging the gap between when a patient gets discharged from one of our hospitals and then they get out into the outpatient. We're using that bridge, and our expectation is that we'll start to see dramatic increases or dramatic improvements rather in our readmission rates, in our medication adherence rates for statins, in some of our partnerships with various payers. We're looking to improve some of their quality metrics, which also improve our patients' health as well. So we're really looking to unlock the value of virtual care in those ways. And while doing that, helping our providers out, because now they're given a little bit more flexibility to use virtual care on their own, how they want to use it with their specific patients. And one quick story, and then I'll end my time. I was talking with a cardiologist yesterday, and he was saying that he loves virtual care for his 80-year-old patients. He says they are the perfect demographic for virtual care, and it's not a young person's thing. He doesn't use it for young people at all. He says it is the best thing for my 80-year-olds, and I want to do more of it for more of them. And I thought that was a great indicator from one of our cardiologists, really about how this can be used for anybody, almost any situation.
It makes sense. Thank you so much, Tyler. So I think I'll just continue in the same vein, and I'll direct first question to Stuart, and then maybe Rakesh. How have you seen, Stuart, virtual care changing since COVID, and how do you think it is shaping up?
Sure. So the first change that we are definitely experiencing is our visit counts are still combined. So this would be telehealth and in person, are somewhere at around 85 to 90% of what they were pre-COVID. What we have found, I mentioned a short while ago, was, prior to COVID, we were seeing about 20 cases on telehealth, on telemedicine a day. That has now jumped to, as I was saying, it peaked and now it's settled down to in the high 600s. It's somewhere between the valley was around 450. Now we're in the mid to high 600s. I believe that these visits, well, we know that most of these visits, about 80% of that number, are not COVID related, and our clinics are open. So we do see moving forward a volume on telemedicine where this now has, and I'm speaking specifically to the virtual visit, has a place in healthcare delivery that I definitely think is going to be longitudinal. So for us, that's the first thing we've noticed. So we are now looking at what's next. And so a couple things for us are next. The first thing, just as Tyler mentioned, I think one of the things we're also trying to look at, aside from reducing institutional costs and streamlining, is where do we kind of like go from here in terms of where do we apply it? What about quality control? We want to make sure that both clinical quality is at least as good and that the patient perception of that quality is just as good. And one note there, I would love to automate all telemedicine and have providers see the patients, check the patients in, everything gets automated. What I don't want to lose sight of, though, at least in an initial phase until the general population is very comfortable with healthcare, is that kind of Publix-like customer service. If a patient today is used to calling the doctor's office and speaking with a scheduler or an assistant, I don't want to necessarily take that away, especially as people continue to get used to it. So I think there is value in kind of a concierge approach, especially in specialty care service lines where patients might have more questions, than it just being kind of a self-service patient provider experience. So we're trying to figure out where do we want to do that, and for how long. And then just to wrap up, just a thought on this, where do we go? So our other focus right now is we have University of Florida has a presence in each of the counties in Florida through our agricultural entity. Most of these are in rural communities. And so we actually did receive a part of that FCC grant, and we are expanding it so that we can go through a cycle of care. I think Tyler was mentioning this too. So if a patient is discharged from the hospital, we might need to see them in person once or twice. Then we might want to see them if they can go to one of these county locations if they're not local to us, and a lot of specialty care isn't, and kind of have a slightly, if you will, attended visit with a CNA or some type of, facilitator for that encounter, and then eventually have them do the visits from home. And so that is one thing that we're also investigating, kind of a care
Okay,
cycle.
interesting.
Thank you.
Thanks, Stuart. Rakesh, any quick inputs from your side?
Yeah, I mean, like I definitely agree with most of our panelists. I mean, we are all seeing the same volumes, right? So we are all seeing 15, 18, 20 times X kind of like multiplier effect from the pre-COVID days to the COVID days and across the span, right? So the patient journey from the home to urgent care to the patient-centered medical home, the urgent emergent, and then acute and post-acute, right? So across that patient journey, we are seeing spikes in all sorts of telehealth. So I won't repeat all those use cases. But I will say, I mean, so for me, strategically, being a loss leader before COVID, right, that's what we were. We didn't generate much revenue. We were sort of like a value-based care and loss leader. Moving to a revenue substitutor, right? So right now we are revenue neutral because we're not generating additional revenue. We are substituting the revenue that because the patient cannot come in. So how do you move from that loss leader to revenue substitutor to a true additional revenue generator? That's where the space I want to get in as a pure for-profit endeavor. I mean, that's going to be critical from being. I see this as a fog of war right now. So literally in the fog of war, many things happen. The HIPAA and all that. It's kind of like CMS allowing so much of that waivers and so many things. All that will settle down. So as that settles down, how do you take again a system-wide approach? I like the concept of physicians being autonomous, right? So that's where we're headed. This is not sustainable if we have to do a lot of handholding. And also the fourth and last thing I do want to see is we talk about digital 1.0 and analog, and then we talk about digital 2.0, which is sort of like a hybrid of analog and digital healthcare. I truly want to move at some point to digital 2.0, where a patient's wearable or a consumer's wearable, an 80-year-old or a young person, will actually say, hey, something is off, either a glucometer reading or something. Let me go to your EMR and see when was your last endocrinologist visit. And oh, by the way, it was more than 3 months. So now let me prompt you to kind of like either schedule that appointment with your endocrinologist. So that's not utopian, frankly. That's happening in some places. So that's where I want to kind of like eventually go with sort of like our digital partners and such. And this will definitely kick the momentum in the right place. So a lot of new responsibility. So that momentum has created a lot of like limelight. So we always used to be in the shadows, and now all of a sudden the spotlight is on us. So it has to be responsible of us to kind of like make sure that we are leveraging that new sort of responsibility and momentum that we have.
Great. Thanks, Rakesh. So, Eric, I have this next question for you. So, we've seen a very tight relationship between providers, and payers are also going through an enormous amount of stress right now. And how do you see this relationship change post-COVID? Eric, you're on mute, I guess.
Thanks. Sorry about that. Yeah, that's a great question, obviously. And, just for anyone in the landscape of telehealth, telemedicine in the past, 4 to 5 years, the biggest pain point has always been about around reimbursement and when payers are going to catch up and having those conversations. Obviously, prior to, COVID, it just exploded because, we're looking to help our patients in any way that we possibly can. So providers were, the payers were coming on board, CMS were changing guidelines and so forth. I mean, what I can tell you about our experiences is we started having conversations with payers probably 2 years before COVID even hit, and trying to renegotiate contracts with most likely the biggest commercial payers in the area. Your Empires, your United Healthcares, your Aetnas, your Cignas, having those conversations, to go down the path of reimbursement. And we actually had 4 of the 4 payers live on our platform reimbursing for virtual care services prior to COVID hitting. Then COVID hit, and obviously things went crazy. And I can tell you that during COVID, we brought up a total of 15 payers. and that includes commercial, Medicare, MA contacts, and also Medicaid. We billed. We were billing through this whole time. Obviously, there was waivers as far as copays and the like for the patients themselves, but we were dropping bills. We continue to drop bills. Our contracts have been revised. They're now part of they're part of our current contracts moving forward. A lot is shaken up in the landscape of reimbursement, and it will continue to do so. There's conversations around whether things will take a backtrack, and kind of go back to pre-COVID days. Is that even possible? We'll continue to move forward. I feel like we're past the point of no return. I think obviously we're just going to keep expanding in the space, and reimbursement is just going to be one of those pieces, right? I mean, we talk the word telehealth and telemedicine all the time, but really it's healthcare, right? It's not even tele anymore, right? It's medicine. It's just another extension, another way to seek care and to provide services to our patients and the like. So I see reimbursement continue to expand. I see it continuing to grow into we're very far down. We've done work, in the real-time eligibility space too, and we're just going to continue to build out.
Okay, great. Thank you, Eric. So I'll just move to the next question, right? And Uma Shankar, I would like to bring you in because this question is about, we've all spoken about how well telemedicine is being adopted and how they were able to seamlessly move so many providers, so many patients into the platform. But I'm sure it's not that easy from a technology standpoint. What do you see as the key role of technology, and what is it? What are the different areas in technology that you see getting accelerated to enable this whole virtual care service ecosystem?
Yes, Siddhant. I think the earlier speakers have spoken about the challenges that they are having with the payers and things like that, right? One of the key things that, as a technologist, that I need to look at, especially since I've been in the IT industry for close to 3 decades and about half of it in healthcare technology, one of the key things that we have to keep in mind is to keep it simple, right? I mean, the moment we in services organization, the moment a customer asks for it, we immediately jump into a session and we say that we love to provide long-term strategies, short-term strategy, think outside the box, think inside the box. There are too many boxes out there. We need to simplify the box. That's the most important thing, right? I mean, and technology has to sort of enable virtual care in a very simplistic form. That's what we do. I mean, you can't expect you can't have an elaborate solution there and say that okay, here is the 15-page write-up for an EMR, fill it up for every patient. That's not going to happen. And we have to be, the first and the foremost thing that the technology guys have to understand is understand what the customer needs and not what we have. That's going to be the key thing. And Eric was talking about how they had to end up using WhatsApp for, I think that's the level of crisis we are handling right now. And so the technology companies have to be nimble in terms of adapting to the changing situations that the healthcare organization system is going through, and have to adapt the solutions to that. And that's not going to be easy, right? So that is where it is going to become more and more important that we look at the right solution for telehealthcare. Not everything is going to fit everyone, but the right blocks have to be taken into consideration to ensure that we cater to the right set of people. Elder care is completely different, whereas this thing is different. So those are going to be some of the technical challenges in terms of trying to understand how things are going to play as we move along. In fact, in our company, we have a remote care platform in which we are actually trying to address some of these multiple medical devices in a very seamless fashion, which is fine. But at the end of the day, all we have to keep in mind is it going to help the final end user or not? So that's going to be the key question, which we will ask ourselves before implementing a solution. Siddhant, you're on mute.
Yeah, sorry. So I'll just move to my next question section, and this is actually looking at the fact that we have so many ecosystem players, we have so many virtual care platforms. So I want to speak to a couple of our panelists who've been through this. So I'll come to Tyler first, and maybe Stuart next, and talk about if you can, Tyler, you can share Your thoughts on what is the key selection criteria for choosing some of these virtual care platforms?
Sure. So I'll be quick. Actually, I'm going to echo, I think, what Uma just said. My note on this was literally, I'm reading it. Technology has to be easy, especially for our patients. The providers we could train, there's a lot of them, but they're fewer than our patients. And we have, I think, one shot with our patients to get them to adapt to or adopt telemedicine. And if we do it right, they'll love it and they'll never want to go back. So beyond that, I think just as a quick addendum that what we adopt has to be done thoughtfully. It has to fit our institution or your institution and where it is in terms of what resources do we have in terms of doctors? Do we have providers with available bandwidth? Do we need to get outside providers? What is the level of comfort, right? And also, we all pretty much, the hospital systems and the larger practices are going to have EHRs at this point. So are we repeating something that exists there? Or are we creating double work? And we want to try to minimize that. That's been some of what I would take away. And the last piece of just unexpurgated advice, I feel that through the years I've been in telehealth, there's a lot of smoke and mirrors. I think the real solutions are actually simpler than the ones that look really pretty, like R2D2 going down the hallway in a hospital. That's a cool visual with limited practical application, at least when I looked at it 6 years ago. So I'm always willing to relook at something, but I think easy combined with the specific needs of your institution is the way to go. And get stakeholders in from all areas of the care team to brainstorm an effective solution.
Got it.
Thank you.
Tyler? Yeah, Tyler, your opinion on this?
Yeah, thank you. So I'm going to add a little bit different perspective. Every week, there are different startups or vendors that reach out to me, and I imagine you experience the same thing, looking to solve a certain problem of ours. And I think what's really helped us when we look at different vendors is clearly defining what is the problem we're solving and how do we want it to be solved. And do we want it to be implemented into our EMR? Do we want to integrate it into a text-based feature or chat or whatever we want, being very clear about that. And then the second thing is every vendor, and Stuart, you said it, every vendor says they can give you the solution you want.
Yep.
I haven't met a sales guy who told me they can't deliver what I needed. And so what we've done rather is engaged a third party named Avia.
Okay.
And we have a partnership with them, and what they do is they scale and scope and do their diligence on all the different startups and all the different companies out there, and they can come back to us with a recommendation for 2 or 3 companies to look at, and then they also have the connections at the health systems or the hospitals that have already worked with the startup or company vendor we're looking to partner with. So then we can get a third party's perspective. We can talk to the companies or institutions that have already partnered with these vendors, and that's really helped us take this ocean of opportunity to a few good potential partners, and then we do our diligence and make a decision from there. So that'd be what I'd add, is to partner with someone else.
Yeah, thank you, Tyler. My next question is just the panel's thoughts on what do product companies need to consider when they build these future telehealth platforms. And I'd like to start with Eric and then get Uma on this. Eric, your thoughts?
Yeah, that's a very interesting question, and it's an interesting space too, because it kind of echoes a lot of what Tyler and Stuart were talking about. When vetting these particular companies out there, obviously, COVID hit, and every time you picked up your phone, it was another new startup trying to solve all your problems, right? Everyone has these multi-$100 million EMRs. They're trying to find a solution in the EMR that we got crushed with COVID financially. Everyone did. They're cutting all their vendors. They're trying to find one solution that does everything for them. The EMRs don't always have the answers, right? Then you get these vendors that are knocking on your doors, telling you that they do have the answers. You go down the path of, do they integrate? Do you want the integration, like Tyler mentioned? And then also, one of the real interesting things I'm seeing now is a lot of organizations are starting to build in-house. They're starting to build solutions inside, whether it's chatbots, whether it's digital front doors, whether it's identity verification to use for their various different telehealth services. So I think the big piece for those players out there and those product those companies that are trying to build a product is, what's the golden goose? What's the golden ticket? Is it building out an all-inclusive product that they think is going to answer everyone's problems, or is it kind of building little bolt-ons that are going to solve for some of the smaller issues that these big health systems are having? That's really the big question. I can tell you right now from a Sinai perspective here in New York City. Obviously we have a lot of vendors. We've done a lot of experimentations out there, but we've also done a lot now internally because of just the financial hit, and maybe the benefits of building in-house, owning it, putting up a little bit more money up front, and then having something, and then working with some partners on the outside. So I think there's a lot that you can question, and I think that there's a lot to think about as being a product builder and trying to get into these facilities and provide a service. But I think they have to find out what it is, what the plan of attack is.
Okay, got it. So Eric, I think we just kind of lost you a little bit, but nonetheless, Uma, I would like to bring you in on
Yes.
Yeah. Sorry, Eric, I think we're just losing your line.
The grand scheme of things.
Okay.
Okay.
So just to add on, I think Eric brought up a valid point, right? I mean, there are players, as you rightly said, who can provide an end-to-end solution or a fix for an immediate thing, right? Today, if someone comes and tells me I can fix all your problems and then and say that I can solve it end-to-end, I think we are talking about someone saying that I can solve world hunger or world population problem and things like that. That's not going to work. So we will have to look at it as feasibly as possible. And I think the frustration is really pouring out from Tyler and Stuart in terms of what they've been going through over the past few months. I think that clearly shows what they've been going through. And I think I can only empathize with what they've gone through over the past few months. And so if you were to ask me as a technologist and not as a product company representing a product company, I would definitely say that first understand what are the concerns that they have and look at the most important concern in the critical path of things that needs to be done, right? And if you're trying to address at least one solution at a time, maybe one brick at a time, I think that might make better sense. Because today, if you go and say, here is an end-to-end solution and here is a invoice for $1 billion, no one has the money. Every money is gone. Everything is gone for running the operations right now. They can't. I mean, we can all say that we can save and reinvest and all those things. That's all theoretically good, but not in the current situation. So from my point of view, I think we just need to take it based on the customer's needs. But the one aspect which I would definitely keep in mind is whatever solution that you're there, keep it as voice enabled. That's going to be something which everyone has to remember, because that will help any type of consumer, because there are people who are tech savvy and there are people who are not tech savvy. But voice assist is something which has been really gaining popularity with Alexas and things like that. So that is definitely going to help a lot. So that's my feelings.
Got it. So I'll just come to my last question on the detailed round, and we'll have an audience section for the next after this question, and we'll have some more guests join for that. So the last question is, and we've got this, massive adoption, and we heard Stuart talk about it rallying and then maybe coming back again. It seems more like the stock market to me. So I want the experts' opinions on how do you see this sustain, right? So where do you think will be the steady state for this? And just a quick 10-20 second input, and if you could put a number to it, that would be great in terms of a percentage. So maybe I'll start with you itself, Uma, if you can give us a steady state idea on where this will reach.
Quite honestly, right, I don't want to put a number or a time frame to this right now, because even the medical fraternity is putting all sorts of research papers out there trying to say this is another 6 months, 3 months, 9 years, 12 years, 9 months. So I really don't want to put words into my mouth. I'm not a medical expert here, but I'm a technology expert. But I feel it's going to stay a while. That's all I can say. I would rather have the other panel members talk about their opinions in terms of where they
Sure.
see it going.
Stuart, what about you?
I think my hope is that this is here to a varying degree to stay. The varying degree is going to depend upon how people that are like our colleagues here and our audience, how we decide to leverage it and bring this to life so that it's not just a band-aid during a pandemic, but something organic that we grow. And that's basically where we're at. And what we've done is and I think we're all doing this, is use this time where the government has restricted some platforms to see what works and what doesn't, and then bring what's working in. And what do people use versus what do healthcare providers use? And what be people, I mean consumers and patients. So that I'm going to share, I'll stop at that point, but this is a very exciting time for us.
Got it. Rakesh, what are your comments on this one?
So yeah, so that's a great discussion. I think if somebody were to put a gun to my head and say what the percent is, I would say about 15 to 20%. That to me is a very aggressive number. But just take a little bit perspective, right? So pre-COVID, we had less than 0.5% of all ambulatory visits, right? So we saw like there's like 1 billion, close to a billion ambulatory visits, 800 to a billion visits that happen in the U.S. On an average. We were less than 0.1% or 0.5%. Nobody really knows. Now we kind of like grew, and eventually I think we'll set it at about 7 to 15%, somewhere in that range. It's also important. There's no method to this madness right now. It's going to be a sliding scale. So I think the key
Right.
term is being ubiquitous, right? So virtual has to be ubiquitous as a way of delivering care, rather than trying to force fit it.
Got it. Tyler, what is your take on this?
Yeah, thank you. I think it's definitely going to decline from where we're at in April and March, and we've seen that. I imagine everyone else has as well. I agree with Rakesh that it's probably going to level out around 20-ish% or so. And as I've talked with my team and started doing some of our financial planning into the future, I really believe the success and growth of it will be driven by the ability for our providers to easily integrate the technology within their workflows. And then the second piece will be if the reimbursement stays the same. I heard a Harvard economist saying that he believes reimbursement will go down eventually. And so if that is the case, that'll significantly impact us as well. Those would be my two thoughts.
Interesting. Your final words from your side, Eric, on this question?
Yeah, thank you. I kind of echo everybody else. I mean, I most certainly don't think this is going anywhere. I don't think it's going to disappear. I think that it's going to continue to grow. I will agree with Tyler. I mean, we're probably down to about 20%, 20 to 30% when we were COVID. So obviously, we were seeing total, and I'm saying the entire institution, 60,000 visits a month or so, or maybe more. And obviously, it's dropped drastically, rightfully so. Hospitals are open, people are coming in, they need to. But I think that it's going to continue to grow out. We're going to continue to scale out. We've done a lot in the outer walls, in the ambulatory space, in the virtual care space. Now we're doing a great deal in the inpatient space and in the emergency departments, with consults and inpatient consults on the floors. I mean, I echo that. You really have to decide how you want to provide the services as a whole. Is it ROI? Are you looking to make money? I really don't think that you're going to see a lot of that, no matter what happens in the reimbursement space. I do think that the amount you're going to see will drop, over time. So you can't build a product in the telemedicine space around that. But how can you create, the overall patient experience? How can you tag it on to population health? I mean, that's a big driver now, right? Being, following the patient from when they walk through the doors to 90 days after their discharge. So how can you provide those services? And again, how can you bolt it onto the current workflows of providers in ambulatory space, other spaces? How seamless can you make it for the patients? right? I mean, that's the biggest piece. They know, they need to be educated on when it's integral that they're seen in person, and they need to know when they can use it and be comfortable with it when they don't have to be seen in person, and when they can do it from the comfort of their home. So it's really, like I said, medicine, right? It's healthcare. It's just how can we expand and build it out and really make our patients out there comfortable with this being part of everyday medicine and healthcare.
Got it. Thank you, Eric. We have about 6 to 7 minutes left, and I would like to welcome now two of our fellow panelists from Harman, Sarika, who is a Senior Director of Healthcare Products and Solutions at Harman. She has tremendous hands-on experience with technology in this space, and also Manish, who is the Director of Product Management, again with Harman. And we have a few interesting questions from the audience, and a couple of them mainly on the technology side. So I thought I will have a couple of them directed to Sarika. So Sarika, I think Uma mentioned about the whole voice technology and how it's going to be important. Can you just elaborate in a minute or so why you think it's important and what are the top use cases there?
Right. So, yeah, in this world, when people are wary of touching anything that is new or unknown, people understand the power of voice. But voice has been there in everyday life for us for many years now, at least a few years now. And slowly it's going to make entry to the care delivery environment, whether you want to talk about the examination room or the reception area. Look at the clinic, right? Just start with the ambulatory services. If you're looking at examination room, just by replicating a natural conversation between a doctor and the patient, and if you enable the doctor not having to look at the screen every time and type out, so much information that they lose focus away from the patients and, lose that contact, lose that connection. If you stop that, and if you just have, a voice assistant capture the information, understand the context, and put that information directly in the EMR, you're going to make the system so easy, so seamless, and there's going to be a lot of information, a lot of important information that otherwise will be lost, will be captured. Or look at the concierge area. I mean, they know people come in and they often complain that they're getting lost in the hospital. If you allow, just a waypoint assistance of, just telling them where to go, where to find this particular doctor, where to find this particular room, it's going to be so easy and so convenient for the patients. And then the examples are so many. I mean, you start thinking out the key. I mean, I think the key is to not think about voice after the fact. Think about voice first solutions and then start building out the system. Uma mentioned that, you have to have the building blocks. And I believe, and we all believe, that voice is going to be a very crucial building block of this whole platform.
Great. That's very well articulated, Sarika. I think it's very clear. Voice first. That I think that should be the new mantra. Sarika, I mean, just maybe I'll take the next question as well with you. There's been a lot of buzz around and questions around wearables. For some reason, we didn't cover this in the session. So, what is your take on the role of wearables in virtual care, and how does it impact? What's the usefulness?
That's a wearable, a very interesting question. Wearable is, our daily life now. We all have wearables. We all wear it. We all track our steps and so many different things. And they have a exactly, they have a very important role to play. So that, I mean, the whole idea of virtual care is not just replicating the examination room interaction, teleconsultation. That's how it's starting out, and I totally understand that's going to take precedence before everything else during these times. But eventually, the care is going to be virtual, where you are going to monitor the patients outside of that teleconsultation and make sure that the patients are okay, keep monitoring them on a regular basis. And that's where the wearables come in picture. Now, they give you the window of the data, when the doctors are not seeing the patients. And that's where the wearables are extremely important. They're on patient's body all the time. They measure the various parameters. More and more, the top wearable manufacturers, at least Apple, Samsung, they're all getting the regulated algorithms in and making it more easily integrable with these platforms. So it's only natural that people are going to look at wearables at giving information about some important parameters and bring them in and integrate that with other clinical information. The only challenge is that every wearable, there are probably 80 million different types of wearables in the market. And it really depends on which one the clinicians approve of using, having the right one, which is more reliable, more accurate, and the data that can be trusted bring in while maintaining privacy and security of the patient. So it's a big topic, but I would just summarize that in a couple of minutes.
Yeah, thanks, Sarika. So I think we're just about time, and I want to bring in one more question, and maybe have Manish, because he has a lot of experience with products and especially looking at the data structuring around it. So the questions we are looking at is especially from a payer side, because they sit on an enormous amount of data. How do you think, Manish, can payers leverage this data, especially in the context of virtual care? So what is your take on that, Manish?
Sure. Yeah. Thanks for the question, Siddhant. So, we've seen a very important trend, in the payer community, and that is a shift in mindset, really. Earlier, data was just seen as an extension of health IT, from a payer perspective. But in the last few years, they've really started to see data as an asset which has a value of its own, really. So and this has really nothing to do even with COVID. This has been happening, for a few years now. Most payers that we talk to are either already using or planning to use data for predictive analytics, identifying high-risk patients, monitoring them, putting them on, let's say, preventive care plans, trying to reduce episodes, reduce bed care days, reduce ER visits, and overall really improve the quality of life for a patient. That is their endeavor. Now, what remote care or remote patient monitoring technologies they do is they really give them longitudinal data, more continuous streams of data every day, potentially with variables like Sarika said, every minute, some data is coming over, and that is really a gold mine that they've started to leverage and kind of also have plans to grow on top of that gold mine of data and use it for their efficiency improvements overall. But there is one more aspect that I'd like to talk about, and that is the overall patient engagement. If you look at the patient community, and look at the trust level they have across different stakeholders in the healthcare ecosystem, across payers, providers, pharma, life sciences companies, and so on and so forth. Payers enjoy, unfortunately, the lowest level of trust. So there is a need for payers, and we see them, in their thoughts and actions is they see the need to engage better with the patients, make it easier for them to access care, using digital health initiatives, wellness programs, making them aware of their own health, etc. So there is data, and there is how we can also connect with the patient through all these technologies that we have and make it really easier for them to manage their condition. So I think there's plenty of stuff going on for the payers as well, as far as remote care or virtual care ecosystem is concerned. They have a lot to.
Yeah. Great, perfect. Thank you. I think we've had a brilliant session. Thank you all so much. I'll just hand it over to Nikhil for the closing remarks of this session. I've thoroughly enjoyed my time here. Over to you, Nikhil.